There we go. So we are recording the session today, so please do not include any confidential patient health information or anything else you don't want heard during the session, particularly during the case consultations, which we don't have today. All right, so our next slide, as you know, we have moved on from Adobe Connect into Zoom. And so in a slide here in a minute, you're gonna have a little more information on how to use Zoom. Hopefully it's been fairly intuitive for you. And if not, then please contact me. And it's kwirling@salud.unm.edu. If you don't have it, get a hold of me or Michelle, and we'll get you set up. So in order to receive CME CEU or attendance certificate today, you do need to announce your names. We'll do that in just a couple of minutes. Here's some information on how to mute and unmute your video and your audio. So if you would like to be on camera and you have a camera, you can click on this, the Start Video Camera button there, and if you need to toggle between different cameras, if you happen to have many of them, there's a little arrow on the side there you can use for that. Computer audio is the same, so just click on the mute and unmute button to toggle back and forth, and to change microphones, it's the drop-up menu there as well. Our disclosure and accreditation statements are on screen now. And we do offer case consultation reimbursements, which we don't do for this session. So if you're interested in that for some of our other series, then please contact Michelle or myself, and we will get you more information on that. And now's the time for roll call. We do have quite a few people on, so we might as well just use the chat box, I think. If you can't find the chat box, it's probably blinking at you right now, down at the bottom of your Zoom screen. So click in there, and you can just type out your list of participants. I know a lot of you have joined as groups, so let's make sure we get everybody their credit. And without further ado, I will turn it over to Caitlin Adams.
Great, thank you. We also have a couple folks in the room joining us. If you'd like to introduce yourselves, please.
Sure. Hi, Brandon Bell, just off screen. I'm also a quality improvement coach here at Envision, and I will very likely be helping Caitlin with some coaching responsibilities this year.
Hi, I'm Carol Conley, and I am the new manager of the School-Based Health Center Quality Improvement Project, in addition to all the other projects. It's great to be here.
So I wanted to make sure that you all got to introduce yourselves, since you'll be working with the school-based health centers. So you can see Carol and Brandon here on screen, and likely you will meet them in the future in our school-based health center quality improvement work. And I think I've met most of you. I'm Caitlin Adams. I'm a quality improvement specialist here at Envision, New Mexico, and I've been working with the school-based health centers over the last several years. And so today we're going to be talking about conducting a comprehensive well exam medical record review. And then later in the presentation, we'll be talking about incorporating youth engagement into your quality improvement goals, which is something new that that OSA is asking of our school-based health centers. So we'll go ahead and dive into, yes. Oh, yes. So first I want to ask folks, through the use of a poll, as you can see on your screen, if you have conducted a medical record review with Envision New Mexico in the past, please select yes or no. It says it can't.
And we are going to have a problem with that.
Oh.
Yeah, I'm sorry.
Oh, okay. So I wanted to try and get a sense of how many have done a medical record review with us in the past. So you're welcome to type in the chat box if you have, or if you haven't. It looks like, based on the names who are folks who are joining us, many of you have. But we do definitely have some new folks, so this will be somewhat review for those of you who already have, and then of course it's going to be brand new information for those of you who have not. So we'll kind of just set the context around preventive care in school-based health centers, and providing high-quality comprehensive well exams is an integral part of the school-based health center model, and for providing preventive care for adolescents in New Mexico. And so New Mexico Department of Health, Office of School and Adolescent Health, adopted a focus on comprehensive well exams last year, in alignment with the National School-Based Health Center goals, as well as the New Mexico Department of Health strategic plan. And so the focus was really around the quality of well exams and not the quantity so much. And this does not include sports physicals. It's intended to be a comprehensive well exam. And so last school year was the first year that all OSA-funded school-based health centers were required to conduct a baseline medical record review for comprehensive well exams using the online tool that Envision New Mexico provides. And so all of the sites, I think almost all 53 participated in submitting a medical record review for baseline information on their well exams. And so we have a lot of really interesting data. We'll share some of the results from that information that we gathered last year. And so the well exams and the medical record review is in alignment with the American Academy of Pediatrics Bright Futures guidelines and also the standards set by Department of Health OSA. And so I want to just note one of the handouts that was provided to you for download as part of this presentation are the recommendations for pediatric preventive healthcare from Bright Futures. It's the periodicity schedule. So if I can have Kevin toggle over to that, then you can have that on the screen, and you can, I'm sure many of you are already very familiar with that. But this is where we get the information to develop the medical record review. So it's based on the best practice guidelines that are delineated here. And so we're looking, for the most part, we're looking at the middle childhood and adolescent care. And so this is where we have how we've developed our medical record review is based on these guidelines. And so one thing I want to point out specifically is the developmental and behavioral assessment. That is something that is also required by OSA in the form of the student health questionnaire. And so by doing the student health questionnaire, you're actually meeting those kind of guidelines within the developmental and behavioral assessment portion of the recommendations. So by doing that student health questionnaire, you're not only meeting the standards that are set by OSA, but also in alignment with these guidelines. So you can use these for reference and know that that's where we're getting the evidence-based information from to develop the medical record review. We'll go back into our slides, and I have provided. Oops, sorry. Okay, so here you're going to see the link to the tool where you actually conduct the medical record review, and we'll go to that in just a moment. And then I've also provided several other handouts for you to reference, and we're going to kind of go through some of those as well. So included in your handouts were the CWE medical record review instructions, the actual form that you can use to print out and conduct a review by hand before entering your data. And then also a guidance document around improving your well exam quality. And then, the periodicity schedule for reference if you need it. So to start the process for conducting an online medical record review, again, you go to that link that was listed on the previous slide, and it will lead you to our online tool that's hosted by UNM. REDCap is the name of the system. And what you do first is, prior to that, is pull a list of the well exams completed in the current school year or since the date of your last review using your ICD-10 codes, and they're listed here on your screen. And these are the codes for your full well exams, and they, again, should not include sports physicals. So based on your full list, you'll randomly select up to 10 well exam charts. If you do not have 10, you can use as many as you have. If you have more than 10, what you'd want to do is randomly select them. So if you have 30 charts, you could pull every third chart. And then again, you're going to go into this online review tool, and for each chart, review and then submit. And you repeat that process for each chart. So I am going to have Kevin turn us over to the actual tool, and we'll walk through the actual process. And again, many of you are probably very familiar. It may just look slightly different than on the screen than last year. There's been some updates to the REDCap system. And so here's a brief, do you think I could use the mouse for the typing? Okay, thank you. So, so this is the introduction, and again, it just provides you some basic information about the guidelines and as well as the codes that you should be using to pull your charts. And then we also have a full document that was included in your handouts with the full details of the instructions, so you can reference that. And then you'll see here there is a PDF of the actual form that we're going to go through now. You can download it as a PDF. So click to download and you can open the file, and then it will just give you a paper version. So it's going to be the exact same questions you would get online, it's just the paper version. So you can print this out and use it if you find it easier to actually go through the tool on paper before entering your data. And many of our sites prefer to do it this way. So then you're going to select which site you're reporting for. So we're going to go down to our test site, but you should see your site listed there that you will select. And then select which number this is. If you're conducting your first baseline review, which most of you would be doing now at the beginning of the school year, you would select this one, and then any follow-up reviews that you would do, you can select second, third, fourth, and so on. Please select the role of the person who performed the review. So if you had a medical provider or other provider, make sure you select which one, and then that will help us to know who was responsible for the review. And we have a little bit of data to share about that from last year, which is interesting. So then select the date of the visit for the chart that you're reviewing. So we'll just say yesterday. And then type in the patient's age. Kevin, if you could just type in a sample age. Okay, and then it's going to jump right into the quality element. So the first one is about immunization status. So the immunization status should be recorded that it was reviewed and up to date. And then you can also mark yes if vaccines were given, or referral or return appointment is documented. That way the student would be up to date. So we'll say yes. And again, this is based on the ACIP schedule, so if you need to reference that, you can Google it and find it based on the guidelines that are provided by ACIP. Okay, so then the next one is on the student health questionnaire. Has the student health questionnaire been completed? And so this element is, again, an OSA standard, but it aligns with the Bright Futures guidelines, and it should be completed on the first visit of the school year, regardless of the visit type, or at a scheduled visit within 30 days of the student's first visit if they're acutely ill or in crisis at that time. If it hasn't been done previously when you're doing the well exam, it should be done at the time of the actual well exam. And the provider should review the student health questionnaire while the patient is in the room with the provider on the date that it's administered, and it should be looked at for risks and also protective factors, and those risks should be assessed and addressed appropriately. So that's what these kind of following questions are about. Was it reviewed, signed, and dated by the provider? And were risks, again, documented and addressed? So if you have any questions along the way, please type them in the chat box. I can pause on whichever point we're talking about and answer your questions. I know, again, some of you may be very new to this, so I'm happy to help answer now, or if you think of them at the end, you can chime in. So the next piece, again in alignment with our Bright Futures guidelines, was anticipatory guidance provided. And age-appropriate anticipatory guidance should be provided during every comprehensive well exam and documented in the patient's chart, including the counseling and education should cover physical growth and development, social and academic competence, emotional well-being, risk reduction, and violence and injury. So this is a really important one that encompasses a lot of information, but again, documenting at least that the anticipatory guidance was provided, and that student health questionnaire can really help drive some of the information that you're going to be discussing with your patient around these topics. The next piece is dental counseling. Was it documented that you provided dental counseling? You can mark yes if the patient has a dental home and that it was assessed, or if a referral was made in the case of a patient who needs a referral. And again, this can come straight from your student health questionnaire. There's a direct question on that, and as long as you're addressing it and documenting that it was addressed during that visit, I think the SHQ just provides that great reminder for you. Then we go on to the next page. Was the blood pressure recorded? Are height, weight, BMI, and BMI percentile documented? All 4 elements are required for a yes and applies to all patients ages 2 to 20. Was a vision screen done? And here again we list, right, that description will tell you at which ages the vision screen should be done. So it should be done every year from ages 3 to 6, at age 8, 10, 12, and 15, and when risk is identified. If the student is not in screening age range or no additional risk is identified, you can select the third option, which is this one. The student is not in screening age and no additional risk. One thing I'd like to note is that Bright Futures updated their guidelines in the fall of last year, and I think they were published in January of this year to reflect that the vision screening does not need to be done at age 18. So that is a change from last year's guidelines. We omitted that information that it does not need to be provided unless there is risk at age 18. So that is a little bit new, very minor, but new. One thing we found in working with sites is that often vision screen is just a routine part of your well exam regardless of age, and that's still great. If you're just doing it for every patient when they come in for a well exam, that's above and beyond best practice. So you can still go ahead and keep to that practice if that's what you do in your clinic. Same for hearing screening. Again, it's often just you do it no matter what the age of that patient is, and if that's your practice, you can continue to do that. And so the audiometric test should be done at every year from ages 4 to 6, at age 8 and 10, and when risk is identified. And again, you have this option here to select if there's not in the screening age and there was no additional risk as to why you would have done one. So we can select that. Was there a review of systems? Was there a physical exam? And a question has always come up about, like, what if the patient refuses or is unable to do the exam for any reason? As long as it's documented that that patient refused, then you can go ahead and mark this as a yes. And then dyslipidemia screening. This was new guidance provided by Bright Futures last year, so it was included as part of our review last year, and it has not changed since then. So a lipid screen with non-fasting HDL or fasting lipid profile should be done once between ages 9 and 11 and once between 17 and 21, or as indicated by risk. So mark yes if a referral was made for lipid screen, if it's not possible to conduct at your school-based health center. If the student is not in screening age or no additional risk is identified, again, you would select this third option. So one thing I want to note, because this came up last year, your periodicity schedule, the sheet that you all can download, will actually, it indicates ages 18 to 21, not 17 to 21. And we talked to Bright Futures publishers about this information because there was a discrepancy between the Bright Futures guidelines and the NHLBI guidelines, which are what are referenced. So the actual guidelines do say 17 to 21, not 18 to 21, but there is a discrepancy because Bright Futures staggers their the age ranges of visits. So starting at 18, it's kind of like a young adult visit. And so they thought it was just easier to group within the young adult category rather than starting at age 17. But we stick to the age 17 because that is really the guidelines that they are referencing from Bright Futures. So that did come up last year, and if you came across that and looked very closely, you would probably find it. But we are aware, and that's the determination was that we stick with the age 17. So if there's any question about that, please let us know. And then HIV screening, again, this is something that is indicated by at ages once between the ages of 16 and 18 or by risk. And then you can mark yes if a referral was made for a confidential HIV screen if it's not possible at the school-based health center or if a student refused testing. So we are finding this that it may be offered, but the student maybe isn't sexually active or doesn't see value in getting this screening at that time. But I think the goal around this is really to normalize the screening. It should be done once between these ages, and that education should be provided around the importance of getting that screening done. So even if the student is not interested or maybe doesn't have a lot of risk factors for it, if they are between 16 and 18, it should be part of your discussion and it should be offered. So I know there was a lot of question around that last year as well, and so we're happy to help answer questions. And of course, all efforts should be made to refer the student to a place that's youth-friendly and can provide that confidential care in a safe space. So then we go on to the next page, and we're looking at medical risk factors. So they should be identified and documented. And mark yes if your risk determination was done for each of the following: DM, hyperlipidemia, tuberculosis, HIV, venereal, gyne, and STD, and anemia. So yes, no should be indicated for each in the chart, and appropriate referral should be given as needed. So these are obviously very specific, and I think this is where a standardized template could come into play, where you're developing an actual template that has all of these listed out so that you make sure you're actually touching on each of them for the students. So let's see. So were follow-up appointments made? And again, this is only if they're medically indicated. So if it's not medically indicated, you can select that option. And then if they were supposed to have been done, but they weren't, based on something that came up during that visit, then you would mark no. And then, of course, if you made them based on something that came up from that visit, you would mark yes. And same for referrals. So mark if referrals were made as medically indicated. And again, if a referral was supposed to have been made but was not made, that's when you would mark no. Another change that we've made this year is we omitted the question around additional diagnoses, and this was based on provider feedback. So if you had answered that question in the past, it is no longer included on the review, as we found that providers felt that they weren't, if a student didn't have additional diagnoses, there was no reason to mark that in the chart. It's just that there weren't any additional diagnoses. So we omitted it. There was a lot of confusion and pushback around that, and so we went ahead and omitted it this year. So once you have completed each of the questions for the one chart, then you select submit, and then that record is complete, and then you go back and start a new record for your second chart. And so it'll bring you right back to the front page, and you go through these questions again for your next patient chart. And I think this is why the paper form may come in handy if you want to print out 10 copies of your paper form and do it by hand, and then have somebody else, maybe your coordinator can actually go in and do the entering of the data. That's what we found works best. But you can also do the chart review, by actually going through the form online while you're doing it. So I'd like to just pause there and see if there's any questions. If there are, please type them in, and then we'll pull up one of the other handouts. All right, I don't see anybody typing in yet, but feel free to type in. So we've also included this document around improving comprehensive well exams, and this really goes through the specifics of everything around how you might address some of these areas for improvement. So if you're not clear about one of the elements that's included in the review, you can reference this document, and it talks about kind of what the best practice is. And it also talks about some potential strategies for improving those specific elements. So I won't go through this in detail, but I just want you to see that it really, that it goes through each piece if you have any questions about it. So let's, I think, all of it. So there's 3 pages there, and then at the very bottom, there's some references. So if you need to refer back to Bright Futures, if you're unclear about those dyslipidemia screening guidelines that we talked about, here's the NHLBI link for those best practice guidelines. Here's the HIV screening ones, and then we have a handbook through Envision New Mexico. We have an EPSTAT handbook, which includes some information as well. The biggest thing here is just documentation. Often we find that, you know, especially with some of the elements for anticipatory guidance or dental counseling, we hear providers say, well, I know it's part of my routine visit. I talk about it, I just didn't mark it, and I didn't write it down on the chart. So that's kind of the key piece in this. And there OSA does provide a health progress note form that's available through the New Mexico Alliance for School-Based Healthcare website, and you can download it and use it as a template if you're if you want to somehow insert that into your EHR, or if you're still on paper, you can use that as a paper chart, and it does include all of the elements. So, all right. So we'll go ahead and go back over to the PowerPoint here. I'm going to hand this to you, Kevin. All right, we'll go forward. Perfect. Okay, so once you conduct your review and you submit to us, please email us and let us know that you have entered your data, because otherwise we won't know when to pull it. So for instance, let's say you only had 8 charts to submit, we wouldn't know if you're done yet submitting all of your charts. So please email us, let us know that you're ready for us to pull the data. That's very helpful for us to know. Otherwise we may wait a while before reaching out to you to determine if we need to pull the data. At that point, then our data team here at Envision develops a fast feedback form, and this is a sample fast feedback form. And as you can see, it has each of the elements that we went over, and it's done in a proficiency model. Given that this is a lot of information, it's complex information, we try and break it down based on some of the foundational pieces of the well exam. So you'll see level 1 includes some of the basics that should be done, including the student health questionnaire, that review of systems, physical exam, immunization status, height, weight, BMI, BMI percentile, and blood pressure. And then level 2 is a little bit higher level pieces, including reviewing and assessing the SHQ, the hearing and vision screen, dental counseling, and anticipatory guidance. And again, a lot of those are driven by the student health questionnaire actually being administered. So really that very first piece is administering the student health questionnaire. And then in order to kind of get to that level 2, you can then go into the risk assessment from there, reviewing it. It also triggers your anticipatory guidance and your dental counseling. So often we see that if you don't meet that very basic SHQ being administered, then a lot of those second elements aren't often done. And also if you're only doing sports physicals, a lot of those pieces will not have been done. So that's why we want this to be comprehensive. So the third level includes some of the higher level pieces that often school-based health centers maybe don't have the equipment or capacity within the clinic, say, to do dyslipidemia or HIV screening, and then also referrals and follow-up appointments are included in that third level, and then assessing and documenting the medical risk factors. So this is what a sample feedback form would look like, and after you submit your data to us, then we would send this back to you typically within a couple of days, and then that way you can start to look at it and see where there might be some areas for potential improvement. So we kind of consider 75% or above kind of passing, and then below 75% is where you'll see like the red X on this sample feedback form, and really targeting those areas where there's a red X those can make for good starting points. And I would say we really recommend starting, again, those level 1 pieces before you move on to trying to improve something in level 2, because often they kind of come together by working on level 1 first. So these really drive your potential strategies for improvement, and reviewing your data often with your team is very important, and looking at this together. If only the provider sees it, or only the person at the quality department who conducted the review sees it, then it's probably not very helpful. And so we really recommend that you get together as a team and look at this to figure out where you want to place your efforts for driving some improvement as a team. So if you're getting coaching from us, this is something we would be working through with you and supporting you in that process of finding areas for improvement, and working with you on some strategies for that.
Excuse me, Caitlin, there was a question that came in privately to me, actually, from Robert Bennon. The health progress note from OSA that we use for our CWEs is dated 8/12/15. Is there a more recent one?
That's a great question, and the Alliance hosts those, and they keep the most recent version. So I may defer to Nancy if you're on. I think I saw you on. If you happen to know if there's a more recent one that's come out and maybe isn't uploaded yet, or if that is indeed the most recent one. But I think whatever is on there should be most recent. So we'll look into that a little bit further, but Nancy, if you want to chime in about that, that would be great. So, so this would be, I just want to note too, if you submit follow-up data, that's something you may be doing right before your mid-year report is due for OSA, and then again at end of year. So that would be one follow-up at mid-year and then a second follow-up at the end of year. We would again provide this fast feedback form to you, but it's a comparative report, and so you would be able to see how you're doing across time. You can see how you started at baseline and how you progressed at mid-year, and then if you do another one at end of year, you can see all of that. So that's really helpful, and it really should be used. You can use that information in your reports to talk about the areas that you improved on, or potential areas where maybe you didn't make improvement. That's all the information really that can help drive your reporting for OSA during those time periods. So Nancy is replying to the question around the updated forms, and it looks like the Alliance is working with OSA to do that, and they're planning to take off some of the dates of the forms. And as far as I know, the 2015 version is the latest accurate version. Thank you very much, Nancy, and that was my understanding as well. So that it was the most recent, and so you can use that form for reference if you need, and it looks like we're going to be working to update that with OSA. So. All right, if there's any questions here about the feedback form, please go ahead and type those in. If you are receiving coaching from Envision, we would again be providing more detailed information, but if you're just doing the well exam medical record review and you're not a site that's being coached by us, we would just provide you with this report. And then at the bottom of the report, you'll see there's a line that says OSA threshold met. And so OSA has set a threshold in which level 1 elements and level 2 elements must be met at 75% or above. And that is how they determine whether or not you'll be working on CWE quality as one of your quality improvement focus areas for the year. So if you have elements that are under 75% within level 1 and level 2, then you would be expected to work on well exam quality for the year as one of your quality improvement focus areas. If you pass the threshold or meet the threshold of 75% or above in each element, then it would not be expected by OSA that you're working on well exam quality. Now, there's one additional piece. Let's see. So regarding the 75% score as pass, this is a question coming in from Robert. Regarding the 75% score as passing, I had assumed last year that this meant for each measure, if 75% of the charts passed, then we were good. But then I found out that the 75% score actually means that 75% of the charts passed on 100% of the measures. So this is where there was a lot of confusion, and hopefully we're clearing that up this year. And I thank you for noting that, Robert. What we are doing for the OSA threshold is by element. So each individual element in level 1 and level 2 must be at 75% or above in order to determine whether or not you're working on well exam quality for the year. Now, your actual reporting measure for OSA at mid-year and end of year is going to be listed on the last line of this form, which is the overall percent of records with all elements. So your reporting measure is different than your threshold measure. Your reporting number is based on aggregated elements, so it's all of them combined. And so that's what that last line is, and you use that last line as your reporting measure at mid-year and end of year. And then that would also determine your baseline. So for this would be a base. This is what we have at the top. It says baseline because it's your first one. Your baseline in your operational plan would be 0%. And then any successive reviews that you do after that, you would use that percent at the bottom to report on. So that's an overall measure, but the OSA threshold is different. So I know it's confusing, and we're happy to clear it up. And if you need to email us, we can look at your data specifically. So we'll make sure you have email addresses to contact us at the end of this. But we do recognize it's confusing, and last year it did look a little bit differently. So we've kind of done our own improvement to try and clear that up this year. Okay, so now I'm going to kind of transition into, now that you know what the elements are and how we lay it out in a proficiency model, I would like to share the information that we gathered and analyzed based on last year's chart reviews that were submitted to us. So we had 53 sites that entered baseline data, and we had about 1,100 charts that were submitted to us from baseline review, which is an incredible amount of data, and it provides us with a great sampling for looking at this information. And then of those 53, there were 40 sites that entered follow-up data at mid-year and then again at end of year. So at mid-year and end of year, we had a total of about 900 charts that were reviewed and assessed and analyzed by us. And so this data comes from those 900 charts of those 40 sites that entered a baseline, a mid-year, and a follow-up. So we're really able to kind of better understand maybe where the common areas are for improvement and where there's some challenges that are kind of seen by sites. So this was analyzed by one of our previous quality improvement coaches, the McCain Scharf, who you probably have met. So this graph shows the percentage of comprehensive well exam charts that met each of the level 1 quality elements. And so as you can see, the majority of the elements were met, and most of them fell above 95%. Whereas there were two areas for improvement here, and as we can see, there was definitely improvement shown across the course of the school year. So immunization status and the student health questionnaire being administered and completed by the student were consistently the lowest elements, even though they did show significant improvement across time. So take note that those are potential areas that you might want to be thinking about where we saw the most need for improvement. So then for level 2, again, looking at those about 900 charts, this graph shows the percentage of charts that met each of the level 2 quality elements. And hearing and vision screening were both consistently met at all time periods, with a slight dip in hearing screening. But all the other level 2 elements were met between 60 and 85%. And the largest increase that showed significant improvement over time was around counseling for dental care and SHQ risk assessment and anticipatory guidance. So again, those 3 areas might be common areas need for looking at and saying, how are we going to improve this? And I think, again, the dental counseling, again, we saw the highest increase there. You can see that in that chart, was a matter of documentation. But the SHQ should be triggering you to be talking about it, but just documenting it in the chart, or documenting that a referral was made in the case of a student who needs a dental home or dental care, should be done. So that's definitely a key piece. And then this chart shows the percentage of charts that met each of the level 3 quality elements. And this area really showed, this level showed the most variability and least consistency in quality. And I think because lipid screening and HIV screening were brand new guidelines, often sites were still just trying to figure out how they were going to get the equipment needed and supplies in their clinic to be able to do this in-house. And so that's kind of, those two pieces were really key last year, and really were the primary focus for a lot of sites. Even sites that met the OSA threshold, often they decided, I still really want to work on these two areas because we, maybe we just aren't familiar with this, and it's new Bright Futures guidelines. So if you aren't familiar with those two screens, or those are two areas that you feel like you need to improve in your clinic, even if you meet the threshold, perhaps you feel like you want to work maybe more on these level 3 elements, which do have a lot of variability. And so that's, I think that just speaks to where we knew that these were going to be higher level things that sites would come across. And then, of course, we have the additional diagnoses listed in there, and we did see some improvement in that area, but we did take it off for this year. So it's no longer included in the medical record review because it just created a lot of confusion and just didn't quite make sense based on what we were hearing from providers. So I definitely think this is some interesting data, and hopefully can help guide your process as you're thinking about your QI focus areas. Many of you have already submitted an end-of-year review to us because you worked on well exam quality last year. If you submitted an end-of-year review, you do not need to submit a baseline. If you only submitted a baseline last year and you passed, you still need to submit a new baseline, so that way we can look at your quality again this year. If you have questions about whether or not you're supposed to be submitting one, you're welcome to reach out to me or Kristen from OSA. We both have that information, and we can let you know if you need to determine whether or not you're supposed to submit one. So one of the other findings that we came across as part of our analysis in the data collection was that when a provider was involved in the review, the site met the threshold elements, so level 1 and level 2 elements, as well as overall elements at a higher rate than when a non-provider person was the only person involved in the review. So there's obviously a couple of possible explanations for this, but often providers know where they're documenting things, and if somebody who's maybe working in a different department who's doing the review, or somebody that's not on site or not part of your team, it can cause confusion and maybe they don't know where you're documenting. So we really encourage a team approach to doing the review, potentially even doing peer-to-peer chart reviews. If you do have quality department staff that are involved, having them actually be part of the full school-based health center team to talk about the process and talk about where you're documenting things. That way there's kind of a standard across the board and everybody's in communication about that. So I think that's kind of an interesting finding, and we gather this information based on one of those first questions we ask you about who conducted the review. So a couple other strategies for improving well exams include pre-visit planning, so ensuring that a comprehensive risk screening, or SHQ, is ready to go, and that you have allotted time before that visit for the patient to be able to take complete the SHQ. Assessing the immunization status from the state, pulling that state registry record in advance of the visit. So a lot of times We see sites that are doing it like the day before they have a patient scheduled, and that way it just goes right in the chart and it's already been done, and then the provider knows maybe what needs to be followed up on with that patient for immunizations in advance of the visit. Checking for the recommended screenings based on age. Again, this is where your support staff in your clinic can be coming in, and if they know a patient is 16, they can make a little note for the provider that says HIV screening recommended, because that's their time. So having everybody on your team and that's going to be involved in that patient care kind of know what the best practice guidelines are and recommendations. That way they can also be supporting the provider as part of the visit. Making supplies available in the clinic. So again, this goes back to the hearing. Here, maybe you need the hearing machine or dyslipidemia supplies for doing the labs and being able to get those labs out. So that's definitely more challenging for sites, but that's something you could potentially work on if it's an area of need based on the information in your feedback form. Creating a standardized template in your EHR, training your providers on all of those elements, and making sure that all providers are using the same template or very similar template, and making sure that you're including a specific spot for referrals and marking if no risks were identified for referrals. Reviewing your well exam data regularly and establishing time during staff meetings. So this is something that if you're receiving coaching from Envision, we're certainly going to be supporting you with. You're expected to do regular data pools and submit the CWE data or whatever it is you're working on to us so that we can continually look at the data, and that's part of the quality improvement process. If you're not receiving coaching from us, it's still something that we highly recommend allotting that time for within your staff meetings or at whatever point you can, so that you're looking at it and assessing where you are. You're welcome to use our tool online to submit your follow-up data. As I mentioned, you can do that at mid-year and again at end of year. And typically we send out a reminder to let folks know what the deadline is for submitting that to us. That way you have it in time to be able to report. If you have a specific need and you want to do one at a review at a different time, you can reach out to us and let us know. That way we know to expect the data, and we're happy to provide that feedback report to you. So again, please, if you have any questions, go ahead and chime in, and then I'm going to switch gears a little bit, and we're going to now talk about the youth participation as part of your quality improvement work. Okay. So I want to also note that we have somebody else in the room join us, and we have Tessa Medina Lucero from New Mexico Department of Health, OSA, and she, you are the youth
Adolescent health coordinator.
That's right, adolescent health coordinator. She's also our youth engagement expert for the state. So she is a wonderful resource who can provide guidance or resources to you for your youth engagement work. And Tessa has been involved in the past in looking at the youth engagement work that school-based health centers are doing, and certainly working with them to support their work. So if you haven't met her or don't know of her, we'll make sure to leave her email in the chat box. That way, if people need to reach out to you, they can reach out to you as a resource for youth engagement. And also, this has been a focus of mine during my time here at Envision. But I am departing Envision in about a month, so certainly, other coaches here at Envision can help support you in this, and also, again, Tessa from OSA. So we'll talk a little bit about the requirements. So what OSA is asking each of their funded school-based health centers to do is choose one of the two quality improvement focus areas as an area where you'll also incorporate youth participation. So when you're looking at your focus areas in your operational plan, you're going to select which one you're actually going to be incorporating youth engagement around. And so this can look a lot of different ways, and this is our first year doing it, and so we're not exactly sure what we're going to come up with, but I think it will help inform some of what the future looks like for how we ask school-based health centers to report on their youth engagement to OSA. And so again, this is new, and it's definitely not going to be kind of a cookie cutter approach. And so in thinking about how you're going to engage youth around your quality improvement focus area, it can be one-on-one patient engagement, and often in healthcare we hear the term patient engagement. For us, because our population that we're working with is youth, we call it youth engagement. Or it can be group engagement, and many of you have already been implementing strategies of youth engagement as groups through your through a youth shack, or maybe you have like a healthy lifestyles group that you're working with at lunchtime. So there's a lot of different things that we've already seen, and a lot of collective engagement that school-based health centers are doing, which is wonderful. But kind of just changing that frame a little bit to say, well, we could actually do something one-on-one. And we don't just have to do one thing. This is not a one-time project. It can be executed in using multiple strategies. So there is a lot of flexibility, a lot of room for creativity in how you approach incorporating your youth engagement into quality improvement. So I just listed some very basic principles around youth engagement here on your screen. So youth engagement is really an approach, not just a one-time project. So think about it as kind of the lens, the means to which you're achieving something by actually partnering with youth. Again, it can be collective or individual, but we also want to keep in mind that just because if we're working with a group of youth, it doesn't mean that they represent all youth, or the one patient maybe that you're working with on something, again, is not representative of all youth. It's intended to be a partnership between adults and youth, and so the lines kind of are blurred in terms of the power dynamics, and it's not about the control being in the hands of the adults. Adults are supportive partners. It fosters growth, development, and skill building. So youth engagement is really a principle within positive youth development, and it's again intended to foster that growth and development and skill building of the youth that you're working with. It is not tokenism, so it's not saying like, well, we have this one patient who represents us when they go to the shack, and so they don't ever talk and they just show up. That's kind of a tokenistic approach. So we want to think about it as like, what is their role? What can they contribute? They have something valuable to offer, and how are they growing and developing as well as part of that process? It also supports youth in making healthy decisions and taking responsibility for one's own health. So this is where in a healthcare setting in school-based health centers, you have the opportunity to support that. And again, that might be something in a group or one-on-one with your patient, but empowering them to be able to take the responsibility rather than doing onto them and telling them this is how it should be, but empowering them to make some of those decisions. Youth engagement, I always get this question, it's not intended only for the youth that are already engaged. We often have youth within our schools who are rising to the top. They're involved in sports, they're involved in Senate, they're involved in maybe all these other things. But we really need to think about how we might engage the other students in the school or patients who are maybe not engaged. And those are especially the ones who maybe need that partnership with an adult even more so. So it's really not just intended for people who are the students who are already kind of, rising as young leaders. And really recognizing that all young people have capacity to support your work and can have meaningful contributions to make. And it should be something that's not just one time, but it's sustained across time. So, and I think this is maybe where we're really trying to shift that frame is we think that it can be done, throughout the school year. It's not just about getting that report in at the semester and saying, oh, we did this one thing, but it's about thinking about it across the school year and how you're going to make a meaningful impact, whether it's with several patients you have or with a group of youth that you're working with on a regular basis. So Tessa, if you want to chime in on anything to add about that, would you like to?
The only thing that I would say is that a lot of times with this youth engagement, you want to engage them in the beginning of the process and not after you've made a bunch of decisions, but include them in that. And sometimes it's hard in the beginning. So you might think about starting to do it at the end of the school year for the next year, and getting some input from young people at that time so that you can start working on your plan for the next year.
Wonderful. Thank you for noting that. That's something too, you're going to notice in your operational plan, there's an option that says under quality improvement, were youth involved in selecting this QI focus area? This year, I imagine that for the most part, that's not going to be the case because of timing, but that's where TESS is kind of going, is maybe next year, maybe towards the end of the year, and you're starting to think about maybe where there's some need for improvement next year. How can we incorporate youth in helping identify what a need is around quality in our clinic, or maybe promoting our clinic? How can youth be involved in that so that then next year, when we go back to our operational plan for next year, we can say that youth were involved in selecting that QI focus area. So again, this year, probably not so much, but be forward thinking about this. Okay, so those are some basic principles, and I have a couple of very basic examples. And the thing about it is that youth engagement is not a cookie cutter approach, and so my examples are really just thought up examples and possible strategies, but they're certainly not meant to just be copied and pasted into your clinic, because every clinic needs are different. Every student that you're dealing with has different needs. So just some basic ideas as to how to approach your youth participation within your quality improvement focus area. So for instance, let's say you're working on overweight obesity. You've already selected that as your QI focus area, and you want to incorporate some youth engagement in that. So a potential individual strategy would be for each student greater than or equal to the 85th percentile, develop a care plan in partnership with the student and discuss with the student what they think is the best form of exercise for increasing their physical activity using motivational interviewing approaches. Schedule a follow-up visit every 3 to 4 weeks and reassess their care plan. Modify the care plan and develop new goals at each visit. So this is just kind of a basic patient engagement strategy, but we've seen a site actually use this and it was very successful. They developed a template around with a care plan, and they had students be able to contribute to that care plan. It wasn't just saying you need to drink more water, you need to do this much exercise. It was about a partnership in that interaction with the patient during their visit, saying what's going to work for you, and helping. Again, motivational interviewing is a huge kind of part of that process. And we have a lot of motivational interviewing webinars if you need to reference them on our website, if this is something you really want to work on. So some potential outcomes of let's say you're working with these students who are identified as overweight or obese on their individual care plans and continuing to follow up throughout the school year. Some possible outcomes. So 6 care plans were developed with youth in the first semester. Of the youth who developed a care plan, 5 carried out their plan. That alone is a success. The fact that youth are going and carrying out their plan because it was meaningful to them is successful. And so don't discount that. I think when we think about health engagement, following through with plans made with their provider is a key piece. So that can be something that you know in your reporting to say, this, we were successful. 5 out of 6 did this. Youth were noting that they felt better, they felt empowered to take charge of their health, and 1 student lost 10 pounds. So your outcomes are not based on what we think your outcomes should be. We are not saying you have to reach 100 students. We're not saying you have to reach all of the health classes. Your individual outcomes for your reporting could be anything. Maybe you want to report the collective amount of pounds lost. Maybe you want to report, a letter that the student wrote after going through this process with their provider. There's a lot that you could do in terms of reporting your outcomes, and it's not intended to be a cookie cutter, because meaningful youth engagement, authentic youth engagement is truly something that is initiated by youth, and we don't know what it's going to necessarily look like. A potential collective strategy for overweight obesity could be talking with the students in the clinic when they're coming in about getting involved with the lunch meeting to discuss how to encourage healthy lifestyles among their peers. This is another example from a school-based health center. They found out, finding out what days and times work best for the youth to meet and providing some snacks during their weekly meetings. So maybe keep a list of the students that you talk to who might be interested, and getting them together on a regular basis. Again, it's about that consistency and that follow through on the adult kind of sponsor's part. So some potential outcomes: a group of 4 to 6 students met 3 times over the semester in partnership with the clinic provider and MA that decided to start a healthy lifestyles blog on the school website and lead a walking group once a week during the lunch period. New friendships were created and they improved their activity level by 30 minutes per day. And they decided to host a table around healthy lifestyles during the school health fair. So again, we may have looked at our youth engagement before as, well, we did a health fair, which is awesome, and it's an important piece of promoting the school-based health center and promoting health. But maybe we can take it a step further to say, how can youth actually be involved in that, and how is it tied back to what our goal is at the school-based health center for quality improvement? Okay. So in the last slide, I have an example about asthma. And so Nancy actually is noting an excellent resource, and it's actually, I'm glad you mentioned it, Nancy, and this is kind of where I got my ideas from. There is an asthma project, and if you are selecting asthma as one of your QI focus areas, they have some wonderful strategies. They actually, let's see, if you need help, the Alliance is offering to support with this area. Information. So for example, in asthma, an individual strategy might be for each student with documented asthma, develop strategies for management in partnership with the student as we complete the asthma action plan. This will include discussing what signs they notice when they're having an asthma attack and what steps to take in the event that they're experiencing symptoms, including determining when to use medication, which medication to use, and how much and how long to use it. We will provide youth-friendly patient handouts to accompany the visit. Possible outcome: here's something that maybe you find out it's not working. The strategy was not fully successful as patients reported confusion regarding the medication management and the handouts were not very helpful. Provider will now implement a teach-back strategy to ensure understanding. Additionally, the provider will help the student identify an asthma partner among their family or friends who's willing to be educated and to provide support. The provider will assess status and encourage adherence during all follow-up visits, even if they're not asthma related. So I think it's important to think about your youth participation as a mini quality improvement process in itself. You're going to find things that are not going to work, and it's about adjusting your process. It's about, again, going back to the youth and saying, okay, this wasn't working, and obviously this handout doesn't make sense. So what's going to make sense for you? How can we make this better? And so maybe your outcomes in that first semester are not as successful, and that's okay. Again, that's part of the process, and it's meant to be a continued process and not just a one-time thing. A potential collective strategy, and this again, where this resource that's in the chat box will come in very handy. Convene a group of asthmatic students or talk to them directly during their school-based health center visit about what they propose to do to make the school environment more asthma-friendly. We will agree upon continued meeting dates that will work best for everyone in the group and discuss next steps and implementation. Possible outcomes. During the initial meeting, students determined they want to research school policy on the indoor air quality. They met with the principal as a first step, then conducted an assessment throughout the school. Their findings revealed that cleaning products and personal products used in classrooms are high triggers of asthma. They're setting another meeting with the school shack to share their findings and open the discussion to explore solutions. So again, youth-driven. It's intended to be a partnership with youth and create opportunities, again, for the youth to go back into their school, talk with their administration, and get involved to be able to partner more with adults and making an impact. And again, it's intended to tie back to your quality improvement goal, an effort to make it more meaningful. And hopefully, maybe you're gonna, because you have this extra focus on your specific quality improvement focus area with youth, you might just be that much more tuned in, and maybe you can report, at mid-year and end of year if you feel like it's making a difference, and if not, how are you going to be adjusting that strategy? So, what we've done as part of this process, if you attended the webinar last week, you would see that there was a scale of youth participation that you can download. on the quality improvement section of the operational plan. So you can download that PDF, and it will help give you some ideas about where you're kind of fitting your strategy. And so our goal is to really, again, be engaging them and partnering with them rather than doing to them, rather than doing for them. So it's a new approach, and I hope that, or at least a redefined approach for youth engagement. There's a ton of material and resources online about youth engagement, so I encourage you to just explore that if you aren't familiar. The National School-Based Health Alliance has a youth engagement toolkit, and I didn't include it as a handout, but you can just go online and view it. If you have trouble accessing it and would like to access it, we're happy to provide that. It has a lot of information and it's specific to school-based health centers, so that's helpful. And anything else? Tessa, do you have any other thoughts that you'd like to add? No? Okay. So just kind of a last thought, if we're working, a lot of sites will be working on CWE quality as one of their focus areas. So do you have any ideas that you might propose for starting with the youth engagement kind of approach to well exam quality? So I'll just pose that to folks, and if you'd like to chime in on the chat box, please do. Any thoughts in the room about how to engage youth around well exam quality, if that was your focus area?
Well, just regarding youth engagement, I just thought it was great how each of those different strategies was kind of reflective of that specific population that the school had, not necessarily an overall strategy that could be used anywhere. Like you said, it's not cookie cutter. So it's just something that reflects the particular interests and needs of your youth and your population in general.
Yeah,
so
absolutely.
That was cool.
Great. Well, we're certainly happy to help as a resource. So if we can provide any support along those lines, we're happy to. Let's see. So Adriana, our team was thinking about students with BMIs over the 85th percentile to also have a collective approach in surveying their cafeterias. That's awesome. That's a great idea. And approaching the staff and principals to ensure healthy dietary change. Absolutely. That's a great idea. Then I think there's a lot that can be done on a policy level or on a school level where youth really kind of drive that process. And I think doing a community assessment or a school assessment is a great first step in getting that going, and it will really drive the work. So excellent idea. We've actually had a site that we've worked with in the past do something similar where they kind of did an assessment of the school cafeteria, talked to principals and staff similarly, and then they were able to actually get an outside nonprofit to provide fresh fruits and vegetables, like, I don't know, a couple of times a week at least, to make them available actually during like a snack period. So I think that was a really cool idea, and they actually engaged community partners. So again, that's another strategy. Don't just limit to the people that you have in-house. Think about your community partners and how they might support your efforts as well. And a lot of times, youth will find, a resource that you hadn't thought of, or have a connection to, to somebody where they could tap in and support the work. So, so certainly not limited to your school. All right. Well, that's all I have for today. So please let us know if you have questions, and the REDCap tool for conducting your well exam medical record review is available now. So the link is available. It's on those handouts. It's on the slides, so you can certainly go to it, explore it, and if you're ready to do your review, you can do so. And just let us know if you're not sure whether or not you're supposed to be doing one for your operational plan purposes. We can answer that. So if we could put Tessa's email in the chat box,
We did. I'll put it in there. one
Oh,
more
did you
time.
already? Okay.
Yeah, but since we're talking about it, I'll go ahead and do that again.
Okay. And then if you don't mind just putting mine in there as well. I think most people have my email, but I think there's a few new people on, so we'll put it on there as well. Perfect. All right. Well, thank you so much for joining us, everyone. Have a great start to your school year.
And if you're still on, we do have a new element to our webinars this year. This is Kevin. You're going to be receiving an email if you signed up for today and with the survey link. And so if you do have some time, please take a few minutes to let us know what worked well, what didn't work well, and what we can do to improve our overall telehealth program. So thank you very much. All responses are anonymous, so be as honest as you possibly can. And we appreciate you coming. Thanks again, Caitlin, and everyone in the room.
Thank you. Take care.
Thank you.
Signing off.